Hydration and IV Therapy, Part 7 for Iowa Lakes Community College. The class is Introduction to Nursing Concepts. This is Martha Olson. Total parenteral nutrition gives us the carbs, proteins, and fats for the patient that is having problems with wound healing, to replace body cells, tissue growth. It helps the patient that is not able to digest in the GI system for some reason the nutrition they need. When we have TPN, the advantages to that are that we can give calories, we can restore the nitrogen balance, give essential vitamins and electrolytes and minerals. For that patient that has wound healing, it improves their tolerance to surgery. It's nutritionally complete, so we know they're getting what they need in the body. Remember, TPN is specifically built or made in the pharmacy for the patient depending on their lab values. So the pharmacist will mix up what they need that fits the needs of that person's body. The disadvantage, you have to have a minor surgical procedure for the catheter or implanted port. There is a risk for a pneumothorax or a hemothorax with the central line. Your patient has to be weaned off of TPN. Just like when we start them on TPN, we have to start them slowly and keep increasing the calories and the rate to get them to tolerate it. We do the same when they're coming off of that. Because of the risk of hypo and hyperglycemia, the nurse knows she will be checking AccuChecks every 4 hours, or 4 times a day, or every 4 hours depending on how it's ordered. And PRN is needed. If you think your patient is sweaty or hypoglycemic, get your AccuCheck done. With hyperalimentation, that's the other name for this, patients who can't meet their caloric needs then would get TPN. It's a very good way to reverse starvation. It adequately helps repair the tissue and promote growth and healing of the tissues. There's less incidence of phlebitis because it's given in a central line. It's nutritionally complete, so it's beneficial for patients that need it greater than 3 weeks of time. Again, because it's a dextrose solution, we may have to regulate blood sugars and use some insulin to also balance out their blood sugars. Our nursing considerations with TPN, again, we want to start it slow, have it on a pump, get our blood sugars done, and it's not necessarily before meals, because with TPN it's running in constantly or continuously, and so your blood sugars may be 612, 612. And nursing order to get daily weights, check accurate INO on the patient to make sure that they're getting enough fluids, having adequate output of 30 mils per hour. And with the daily weight, make sure that we're getting it on the same scale. Monitor your vitals on a regular basis, your signs of infection because of that central line and the amount of sugar bacteria like to grow. And then we also look at our policy for lab values that would be drawn. Usually it's on a daily or every 2-3 day basis to be able to let the pharmacist then mix up the amount of TPN that would be appropriate for that patient with electrolytes, with calories, everything they need. When we look at our central line then, we know that they are very commonly used. It's a common source for bacterial entry, and so we have to treat a central line with sterile technique and watch very closely. The organisms migrate down the catheter, they colonize at the catheter tip, and then once they enter inside and via a contaminated hub or something, so we want to do what we can as nurses to wipe the catheter hub with alcohol each time we access it, do our dressing changes as per protocol of the facility. There's about 5 million catheters inserted every year. We know that there's a lot of catheter-related bloodstream infections. 7 days of extended hospital stay can be tacked on when you have problems with central lines. And so we want to make sure that we follow the policies and protocols of the central line. As you can see, this one has 3 ports. Each one of them could infuse something different. If you had blood, if you had fluids, and if you had an antibiotic hanging, you could have all 3 ports infusing at the same time. The biggest thing to remember is fluid overload. If you have each of them running, what is the total fluid administered at any one time? With central lines, we want to make sure that we have very meticulous hand hygiene. The CDC recommends hand washing before and after insertion, as well as replacing accessing or dressing the central line site. Our alcohol-based hand rubs can be used unless the hands are visibly soiled. We prep the skin using that side-to-side motion, creating friction so that the antiseptic agent reaches the contaminants in the layers of the epidermis. Wait a few minutes, let it dry. Wait for the skin to dry, or the bacteria won't die when we're prepping that skin. The site where the catheter is inserted is the primary risk factor. The subclavian vein poses the least risk for infection, followed by the internal jugular. We don't use the femoral vein because of the high risk for infection. If the catheter is not being used, then the catheter probably needs to be removed. Advocate for your patients. Everyone has to be in the sterile gown, mask, cap, and gloving when the line is inserted, usually back in surgery. And we want to watch for those red flags for a bloodstream infection that can be as a result of a central line. Your fever, chills, tachycardia, hypotension, leukocytosis. Blood cultures are needed when we want to figure out the source of infection with that central line, because a positive blood culture in the bloodstream then is treated very aggressively to get that under control. When we are troubleshooting with our central line, remember air can enter the central line during insertion. If the caps aren't tightened at the ports, when you change a cap and the ports are not clamped or closed, when we remove the central line, air can enter the bloodstream and be life-threatening. So while the doctor is removing the central line, the patient would hold his breath to avoid that complication. Inadvertently cutting the IV line when changing the gown or tubing, so don't ever use the scissors near the central line. And then, as we talked about in class, we only want to use the 10 cc or 10 milliliter syringes to access, because the smaller ones exert more psi or pounds of pressure and can rupture that catheter. If an air embolism does occur, cap or clamp the port quickly. Immediately put the head of the bed down, turn the patient onto the right side, because it traps the air in the apex of the ventricle and it lessens the chance of air getting into the pulmonary circulation. Give your patient oxygen, monitor vitals, lung sounds, heart sounds, and report any changes if you have air embolism for that patient. When we flush the line, never force anything down through that catheter, because a clot could enter the circulation or rupture and embolize a piece of the catheter. And if you're not able to flush the line, then clamp it off and do not use it. If we have a patient with a fever, we want to assume the cause is the IV line unless we can figure out other causes for that. What are the contamination causes during insertion? Make sure that we have the patient turn his head away when we're doing a dressing change, cough away from the site of that central line. Good hand washing, frequent assessment of that site, and then make sure our dressing changes are completed in sterile fashion. So as we look at a physician for your patient has just ordered an IV infusion, you're attempting to educate the patient on why they would need the IV. Your patient states, "I'm not going to let you start an IV on me." The patient is pale, trembling. The palms of his hands are cool and clammy. What would you say? What would you do? And what is our responsibility? And what are the rights? Can a patient refuse an IV? But yet when you notice the assessment that's listed up there, it tells you that that patient is probably becoming very diaphoretic and trembling because of hypovolemia or some other issue where they do need an IV right away. Switching gears up just a little bit, we look at our blood and blood products on page 909 in the Potter and Perry. We know blood transfusions save lives. And with blood products, we have a lot of nursing implications that go with that. Our blood transfusion, again, is by the ABO system that we use, what type of blood you have. If somebody volunteers, is a volunteer donor, they are then considered a homologous donor, whereas if a patient knows he's having surgery and will need his own blood, he would then be an autologous donor, auto meaning self. Type O is your universal donor. That's why the blood banks are calling me all the time. And your type AB can get any type of blood. They are what we call your universal recipient. The presence of that specific antigen on the red blood cell determines what type of blood a person has, and they usually know this from birth because this is something that they will check on a newborn, and it will be recorded or documented. As you can see from the blood bag here, this is a person that's B positive. The patient has gloves on, or the nurse has gloves on when they are handling the blood product. They go to the lab, they sign it out, they check it out with the lab personnel that it's the right date, the right time, bring it back and get it started on the patient, because you have a very small window or time frame to be able to hang blood, simply because it's a protein and it will grow bacteria if it's left at room temperature for too long. Interesting enough, when I was on a cruise a few years ago, when we went down and looked at the ER that they have on the cruise, that's the one thing the nurse said that they are not able to do is administer blood products, because they have no way of having enough blood on board the ship, that if a patient was critical enough that they would have to helicopter them out because they can't give blood products. Our whole blood then is never the preferred treatment. It contains red blood cells, white blood cells, plasma, and it's not really used because individuals don't need all that fluid or plasma. It's usually saved for that massive trauma where the individual needs the volume as well. When we look at the packed cells, it's what's left over after we remove the plasma from the whole blood. It's used for routine blood placement during surgery, or those patients that have hemorrhage during surgery, or they come back to the unit and have a very low hemoglobin. Those patients that are anemic, they're not able to carry oxygen. The white blood cell remains and are usually associated with febrile reactions. So now it's a very common practice today. The white blood cell is removed, and that is called a leukocyte poor blood transfusion. The blood is washed with saline to remove the white blood cells, and we also have a leukocyte filter that may be used to help decrease the transfer of white blood cells to the patient. So all they're getting is packed red blood cells. Our fresh frozen plasma is removed from the donated blood and frozen within 6 hours of collection. It's thawed just prior to the infusion or the transfusion, and you would just call the lab and tell them to get the fresh frozen plasma ready. By the time it's taken out and gets to the patient, it's usually thawed because it's in a very small, little shallow bag. It's very rich in clotting factors, so your patient that has a clotting disorder would be your patient that you would expect to administer fresh frozen plasma. With the fresh frozen plasma, it's usually your patient with liver disease, again, because your clotting factors are made in the liver, and if the liver is not working, your patient will have clotting problems. The person on Coumadin who's going to surgery, uncontrolled bleeding, might get fresh frozen plasma. With fresh frozen plasma, I remember the last time I ran plasma in, you just kind of open the bag and let it run in. It doesn't have to be on a pump and looked at very often. It's a very small bag that's administered, and the patients tolerate that fairly well. Other blood products are the platelets. They come in a single unit from multiple donors or multiple units from single donors. Again, they're used for bleeding disorders from illness, meds, trauma, organ dysfunction, and they don't have to be cross-matched prior to the infusion. Your cryoprecipitate then is obtained when slowly thawing unit of fresh frozen plasma. It's a protein. It's very rich in clotting factors, again, for your patients that have clotting factors or disseminated intravascular coagulation, or DIC. And then your granulocytes are prepared by separating the white blood cells. Very rarely do we just give the white blood cells. It has to be transfused within 24 hours of being collected, so it's very time sensitive. And patients who get these types of transfusions must have a very low white blood cell count, that they're not responding to other medical therapies, and there's must have a reasonable chance for some bone marrow recovery before we would administer our granulocytes. So again, granulocytes are the white blood cells. Your packed red cells are red blood cells that are given. When we go to give blood, we always look for the order. We do the teaching, get the consent. We have to think about why the patient needs blood. The IV is needed. We need an 18 or 20. 20 is the smallest that you can have in to be able to administer blood. How long will the transfusion take place? And we have to remember some of the patients will have a transfusion reaction that we have to be alert to the signs and symptoms. Your anxiety, your hives, itching, fever.